Hello everyone. In continuation with the topic of depression, today I will be talking about the treatment of this problem. Now before we start the treatment of depression, I would like to give a disclaimer that the content of this presentation are for information and education purpose only. The content is not intended to be a substitute for professional medical advice, diagnosis or treatment. Always seek the advice of a physician or other qualified health provider with any questions you may have regarding a medical condition. Now, the treatment of depression is broadly classified into 4 categories. One is psychotherapy, which is a very essential component of the part of the treatment. Then pharmacotherapy, that is drug treatment. The third one is transcranial magnetic stimulation, TMS. And the last one is very well established and the known treatment is electroconvulsive therapy. We don't call it ECT or shock therapy. Now, we are discussing here with primarily the pharmacotherapy of depression. As we have seen in the previous presentation, that antidepressants are broadly classified into 4 categories. One is selective serotonin reuptake inhibitors, SSRIs. Then selective noradrenaline reuptake inhibitors, that is SNRIs. Monoamine oxidase inhibitors, that is MAOI, and other drugs. Some of the drugs which do not belong to any of these category are like bupropion, which is a dopamine reuptake inhibitor, vortioxetine, which is having a very complex mechanism of 5-HT blockade and also a partial agonist, trazodone, and ketamine. Ketamine, we have seen it is an NMDA receptor antagonist. So these 4 drugs few more drugs are classified separately because they are not in the conventional classification of antidepressant drug. Now, the point which is important to note, there are several categories of drug, a few more categories of drug which are used in depression, but they are not classified as a classical antidepressant drug. They are like anti-anxiety or anxiolytic drugs. They are very commonly used for depression. Then hypnotics and sedatives, antipsychotics, psychostimulants, antiepileptics, and lithium. These drugs, which are not antidepressant by category, by classification, but they are very commonly used, are in certain situations, they are used along with conventional antidepressants. The first category of anti-anxiety drug are in fact used sometime as a single therapy for depression without antidepressant drug, and it is one of the most commonly used class of drug which is given in the treatment of depression. So this classification is also important to know for a depression. Coming to psychotherapy. Psychotherapy is used for mild depression only as a single modality of treatment without any drug treatment, and it may be effective. But psychotherapy is also used in cases of moderate to severe depression, but always in combination with drug treatment. So psychotherapy plays a very important role in the treatment of depression, whether it is mild, moderate, or severe depression. Again, to emphasize that for mild depression, psychotherapy alone may be effective without drug treatment. Now, when we come to pharmacotherapy, there are several guidelines which are given. If you see the treatment guidelines of various countries, you will find by and large they are same, you can say, but there are certain differences. I will try to highlight those differences in the guidelines. The most important point about pharmacotherapy is that for treatment of depression, most of the guidelines recommend SSRIs as the first line treatment. This is very important. that this class of drug, as we have seen in the previous presentation, is considered to be safe alternative, is an effective alternative to the earlier conventional drug like tricyclic antidepressants. So SSRIs are recommended as a first-line treatment by most of the guidelines. Now, among the SSRIs, like we have seen fluoxetine, arperoxetine, arfloxamine, sertraline, which is citalopram, which should be used. So there is no clear-cut recommendation in most of the guidelines that which drug should be used, because any drug of SSRI class can be used. Though the doctors have a preference, there are some preferences depending on the countries and the availability of the drug, but by and large we say that SSRIs as a first-line treatment for depression. The Amitriptyline, which is basically a tricyclic antidepressant, is a first-line treatment in Colombia. Just it's an anecdote. You can say it is slightly different than most of the recommendations, that they recommend amitriptyline as a first-line treatment. It is highly effective, no doubt, but unfortunately it has got a high discontinuation rate because of the safety issues. Tricyclic antidepressants are not suitable for the long-term use, and especially they are not suitable for the older age population because of their multiple actions and multiple side effects. So tricyclic antidepressants, they have H1 blocking effect, which causes sedation. They are also having alpha blocking effect, leading to postural hypertension, again very common in elderly population. And also they have anticholinergic or antimuscarinic effect, which leads to the problem of dryness of mouth, urinary retention, and glaucoma, etc. So we should be aware of the side effect of tricyclic antidepressant, particularly in the older population or people above 60 or 65 years of age. But somehow amitriptyline is a first-line treatment in Colombia. But most of the countries, including India, we find that the common treatment to start for depression is SSRI. Now, in some countries, mirtazapine is also a first-line treatment. Now, we have understood in the last presentation that mirtazapine is a drug which has got significantly sedative effect. It has got a good sedative effect, and it is a very suitable drug, or it is a preferred antidepressant for patients who are having depression with insomnia as the major symptom. So it's a good drug, and in some countries it is recommended as a first-line treatment. Then the 3-4 drugs like agomelatine, mianserine, milnacipran, they are first-line treatment in Canada. Now, these 3 drugs, in fact, none of them is approved in US, but they make the first-line treatment in country like Canada. If you see agomelatine, mianserine, milnacipran separately, you will find that they are very safe drug, and their safety is very, very good. But somehow their efficacy is having, you can say it's a modest efficacy. We can't say it is very effective treatment. But yes, they are used in countries sometime as a first-line or even second-line treatment. Then once you start the treatment with any of these class of drug, then you have to maintain the therapy, as we have seen that the treatment continues for 6 to 9 months, or it is given for a period of 9 months plus the duration of depression, or sometime in chronic cases, which is more than 2 years, it is given for lifelong treatment. So depending on the maintenance treatment depends on the number of earlier episode, it depends on the age, depends on the coexisting condition like a cardiac problem or kidney problem, and etc. Depends on the severity of depression, whether it is mild or severe. It also depends on the risk of suicide and also the risk of hospitalization. So deciding the maintenance treatment on a particular drug, on a particular dose, on a particular duration will depend on all these factors for each patient. Now, once the treatment is started, as I have told you that about 1/3 of the patient, they respond significantly with the class of drug that is given or with the first or second line treatment. But 2/3 of the patient, they either show partial response or they show no response at all. So for those patients, what to be done? So the very first thing which we have to find out is medication compliance. Are the patient taking medicine as per the recommendation, or because it's a common practice among these patients to skip the medicine or stop the medicine for few days and then again start, or take on as and when necessary basis, whenever they feel that it is required, etc. So medication compliance is definitely a challenge, and you can say that almost 40 to 50% of the patient may not comply with the treatment as per the recommendation of his physician. Then the second thing is, if the compliance is good, then check for the dose adjustment and the increment. Sometimes the patient who is taking or starting with the lower dose or the initial dose, he may require some doses modification on the higher side, and you have to combine the treatment or you have to adjust the dose accordingly. The third option is that you can replace the drug. Means if somebody is taking SSRI, you can replace with SNRIs. So one is the replacement of drug. Now when you talk to the replace drug, there are two possibilities. One, you replace one SSRI with another SSRI, or you entirely give a different class of drug. Like in UK and Colombia, they prefer to replace the same class. For example, if the person is taking fluoxetine or paroxetine, they can stop this and they can continue, they can start with, say, escitalopram. So both are SSRIs, but they shift from one drug to another drug. This practice is quite common in UK and Colombia. But Canadian recommendation says that you should replace the different class of drug. So if the patient is not responding to one SSRI, it is unlikely to respond to other SSRI. So change to different class. May say SNRI or other tricyclic antidepressants or other class of drugs. And the last option is that if all these things fails, then you have to go for a combination therapy, or you can go for an augmentation therapy. Combination therapy means you combine two antidepressant drugs, and augmentation therapy means you combine one non-antidepressant drug with an antidepressant drug, as we have seen in the categories. Now, when we say augmentation therapy, say for example, it can be combined with antipsychotics. Almost all the guidelines, including American guideline, European guideline, they recommend of combining antipsychotic with antidepressant drug if patient is not showing any response or if he is showing a suboptimum response. In US, guideline recommendation is to combine with monoamine oxidase inhibitor with the existing antidepressant therapy. Mirtazapine is a preferred choice in UK. Similarly, lithium, which is a mood stabilizing agent, is almost recommended with all the guidelines to combine with antidepressant if it is not responding. And only one guideline, that is of American guideline, American Psychiatric Association, recommend using thyroid hormone along with antidepressant as a combination therapy. So you can see there is a wide variation to some extent. There is a wide variation from one guideline to another guideline in different categories of treatment. Now then, coming to the type of depression. When we say types of depression, basically they are all major depressive disorder, what you call MDD. Now in these MDD, there are few presentations may be more exaggerated than the other. And based on that, the depression is classified into 3 or 4 categories. So coming to the first one, like psychotic depression. Psychotic depression means when the patient with depression having psychotic features. Psychotic features means he may have delusion, he may have hallucination. This hallucination can be visual hallucination, or an auditory hallucination. Now we will discuss these psychotic symptoms, etc., when we are talking about schizophrenia and other antipsychotic drugs. But just to tell you in short, that psychotic depression is characterized by depression with the psychotic features, where hallucination and delusion could be very prominent. Then catatonic depression is the depression with catatonia. The catatonia means the patient has entirely immobile, or he prefers to be immobile. He is mute, doesn't respond. Besides depression, he is absolutely in his own world. That is catatonic depression. The third is depression with atypical features. Now this atypical feature could be very strange, the loss of appetite or excessive appetite, or few unusual symptoms along with the depression. So this is the depression with atypical features. Now if we see the depression with melancholic features. Melancholic features means extreme sadness. Melancholia means the patient is depression having a very sad mood, very low mood. But in case of extreme depression, this is depression with melancholic features. Actually, this is, you can say, it is a form of depression which is very, very severe type. And quite often, the last type, which is depression with somatic features. Patient with depression has got some kind of somatic features, as I have told you last time, that they may have some kind of pain, headache, body ache, abdominal pain, some kind of vague somatic or physical symptoms which are there. Now coming to the treatment of these individual types, the psychotic depression, the treatment is given with antidepressant plus antipsychotic agents. For catatonic depression, the choice is given antidepressant plus benzodiazepines. Again, we will see this class of drug in our subsequent, especially when we are talking about anxiety, because benzodiazepines are used primarily in the treatment of anxiety disorders. For catatonic depression, you can also give antidepressant plus barbiturate, which are hypnotic and sedatives. So any of these two class of drugs can be combined. The depression with atypical features can be combined, antidepressant can be combined with MAOI, that is monoamine oxidase inhibitor, which is like moclobemide, which is a selective MAO inhibitor, or phenylcypromine, which is a non-selective monoamine oxidase inhibitor. The SSRIs can also be combined with bupropion for the treatment of depression with atypical features. So depression with melancholic feature usually is treated by SNRI, selective noradrenergic reuptake inhibitor plus tricyclic antidepressants. And finally, the depression with somatic features has no specific treatment. So any of those class which we have discussed in depression can be used for depression with somatic features. So what we have seen, that we have seen the categories of antidepressant drug, we have seen the categories of non-antidepressants which are used in depression, the role of dose modification, dose increment, and combination therapy in patients who may not respond or who are partial responder in cases of depression. Also, in different types of depression, there are different combinations which can be combined for getting the best results. Now, in next presentation, we will take individual drugs or the specific drugs with their pros and cons, where to use and where not to use those drugs in the different situations. Thank you.